Thank you guys for being here today. We're really excited. I'm personally very ecstatically invested in this topic, and it's one of my favorite things to talk about. But we wanted to take a brief moment and introduce our speakers today and thank them for being here to speak from their expert opinion. First up, we have Jemma Woodgate, who is a senior dietitian in Queensland Children's Hospital from Australia. So we are very grateful for her because it's what I believe is incredibly early in the morning there, right, Jemma?
It's not too bad. It's 7 a.m. It's
Oh,
perfect.
okay. Could be worse. So thank you guys for being here a little bit later in the day than we normally do this on the Eastern time zone to be able to accommodate a little bit of more of an international presence today. She has a special interest and does research on nutrition and ECMO and is actually actively working on some pretty big projects I hope she mentioned, such as developing a nutritional guideline consensus statement for internationally for children on ECMO. Amy Lee is an associate professor in the Department of Pediatrics at UT Southwestern Medical Center. She is the medical director of their PICU, who is the primary author of the most recent ELSO guidelines on nutrition in pediatric ECMO patients. So something that I'm sure you guys would guess we will be referencing today. And then Dr. Marwa Mansour comes to us today from Baylor College of Medicine and Texas Children's. She's very active in nutrition and research and just had a publication accepted that I hope that she references today as well in reference to ECMO nutrition. So a couple of experts today with us, and we're excited to see what they want to be able to teach us.
Thanks again, everyone, for joining us. And just to kind of outline what this hour will look like, we're going to do case-based vignettes, and then each of these case discussions will be followed by expert opinion. We'll be leaving the cases up for the majority of the conversation and have some directed questions after that. Thank you, Elise, for looking at the chat and interrupting us as needed, or bringing up questions at the end as it feels appropriate. And so with that, let's get started.
One more thing to mention is that if you are not actively on our current PediECMO listserv and to receive our emails and you received this through another format or it was forwarded to you, please let us know and we can send you the link to sign up to be able to be more actively a part of our distribution list. So back to the case. Our first case is a 9-month-old boy on VA ECMO via neck cannulation who on hour 29 due to flu and multi-system organ failure, his lactate remains unchanged in the 5 to 6 range, so continuing to kind of struggle. His MAP is below the target goal of 42 to 46, and his ECMO flows have ranged adequately from 110 to 150 per kilo with varying doses of pressors and vasopressin to achieve target mean blood pressure. So we kind of start this conversation.
Yeah, thank you for reading that case stem for us. To start off this conversation, why don't we start with Dr. Mansour? Can you tell us how do you personally define the idea of too unstable to feed?
Well, that's always left to the discretion of the physician, but I will tell you, usually what happens is if the patient does not need any resuscitation treatments, like he's not getting any fluid boluses, escalation on the vasoactives, and any resuscitation maneuvers for at least 6 to 12 hours, they will not be deemed stable enough to start enteral feeding. And I'm saying up to the discretion of the clinician because usually there is a huge variability on the perception of clinical stability. Some people will say, well, being on calcium drip is enough to say, well, they're too unstable. Others will be like, well, if the MAB is achieved, despite the fact they are on calcium drip, in addition to other vasoactives, they will be stable. The other objective parameter is the lactate. If the lactate is downtrending and below 3, then they will be stable. If they are more than 3 or increasing, then they will be unstable.
So kind of along those same lines, Amy, do you and your team kind of have specific clinical indicators that are set that guide your decision, whether it be vasoactive scores or fluid balance, lactates, like she just mentioned, or is it more physical exam, or is it something that's kind of case-by-case gestalt per patient? And we'll talk a little bit more about that for some later questions.
Yeah, I would say it's all of those things combined. So I agree with Marwa. It can be so subjective, but there are a few objective factors that we can consider, such as the lactate. If you have NIRS, Both the head and abdominal nears have been really helpful in those types of situations. When we were writing the nutrition guidelines for ELSO, they took 3 years to write, and that was for a reason, because no one had a hard time agreeing on what the consensus should be, both within the group and then according to our peer reviewers as well. So, and this is an international collaborative, so people across the world have varying definitions of what stability is. But I think if we could all agree that you've accomplished the goals of what you wanted to do and you've been able to say your patient is resuscitated, that equals stability, but that's going to be different for every single patient.
Thank you so much for that. And then when we shift away from enteral feeding, but think more about the timing around parenteral nutrition and the consensus for that, Dr. Woodgate, I was wondering if you could maybe comment on what's the right time for that or when you would consider that.
Yeah, look, I think this is a really good question and also one that doesn't have a clear answer. So 3 statements that I'll put out there is that we know in this population that protein needs are really high in our pediatric patients supported on ECMO. We know that based on many studies from the literature that PN is required to meet nutrition targets in this population. And we also know that early PN is not necessarily good. If it's not carefully managed, it can contribute to overfeeding in the early acute phase. Based on the ELSO guidelines that Amy has written, it suggests commencing PN by day 3 to 5 in neonates or malnourished patients and day 7 in well-nourished pediatric patients. In my practice, I would be considering the feeding route options from the very beginning. I'd be asking, is this a patient that we think will be suitable for enteral feeds? Do we think that we'll be able to establish adequate protein and calorie intake in a timely way? And if the answer is no to these questions, then I would be flagging a PN not super early, but early on in their trajectory with my team to consider. And based on a survey of practice that our facilitator, Jamie, has led in the US and Canada, it looks like that I'm not necessarily alone in that. 50% of physicians and 75% of dietitians report commencing PN in ECMO patients within 48 hours of ECMO cannulation. So I think it's a really grey area as to when the right time is. And I'm interested to know what the rest of the panel think about that.
And of course, anyone in the audience is feel free to speak up as well from their own expert or advice.
I'd be happy to chime in now if there aren't any other comments from our the audience. So I think also additionally what's important is at times we consider nutrition to be an ancillary part of a patient's management. When we put them on ECMO, we're so worried about the heart or the lungs or the brain that we forget that nutrition is absolutely essential for healing and recovery and survival. So that I really tried hard to say, okay, day 1 of ECMO, day 1 thinking about nutrition, and all the things that Jemma mentioned is like, this is not something to think about 2 or 3 days later, which I think we've all probably done. It's like, oh gosh, I forgot about feeding this child. It really should be one of the first things that we think about. And within the reason that we decided between 3 and 5 days to put in the guideline is because there was lots of evidence for 7 days, there was lots of evidence for 3 days, so we just said that's the range, which we would recommend. And I think a lot of institutions split the difference and choose 5, but I'm interested to see what other patients do, what other institutions do.
Well, it's refreshing to hear you because in Australia and in Texas, it seems to be the same struggle. So in our recent publication, what we did in a retrospective study, we tried to look into it, to look at do we treat patients differently if they are on VV ECMO versus VA ECMO? When do we make the decision of starting feeding? And do we prioritize starting enteral nutrition or parenteral nutrition? And what you highlighted about this huge variability between providers, because even though there is guideline, but still the comfort level of each provider to start enteral diet is very variant. And the other thing, a lot of biases happen because how the patient was sick before they went on ECMO. So the patient who went on ECMO is either somebody who was transferred from another facility, or a patient who came very sick to the emergency room, or a patient who was already in the ICU for a few days before all the conventional treatments failed and they eventually ended up on ECMO. So how sick they were before affected our decisions on how to feed them. So patients who were stable enough to receive some enteral diet within 48 hours before they went on ECMO were more likely to be on enteral diet within 1 to 2 days after ECMO, while the patients who were more sick or patients who came with septic shock or cardiogenic shock and needed VA ECMO were very late to start enteral diet, maybe up until day 7 or day 10. And interestingly enough, by day 7, despite stability, 50% of the patients were still on TPN just because they were intolerant or because we haven't done enteral diet recently, so maybe they will not be tolerant. So there is a lot of bias and a lot of fear that maybe not yet. Exactly as Amy said, it's looked at as an ancillary decision to be made, not a part of the core treatments that should be delivered to the patient.
Is there anything else from the ELSO guidelines, Amy, that you wanted to bring up about just kind of safe feeding and transitioning into not feeding, but how to do it safely and recommendations?
So a couple of comments that we noticed as we were forming the guidelines is that we did find that a lot of people were still really hesitant to start lipids because of the concern that it will clog up, the filter and disrupt the circuit. And there wasn't a lot of evidence for that ever since the materials of the filter and the oxygenator actually had changed. And so when it went from this polypropylene membrane to this truly like what seemingly is non-porous membrane, we didn't really see any evidence of that. And so we encourage TPN. If you're starting TPN, we encourage lipids to start at the same time. And that is, I still think, sort of a controversial opinion or part of the guidelines, or at least it's one thing that I get asked a lot of questions about is, do you really think that that's okay to do? And I really do, which is why we put it out there and why these are peer reviewed. The other thing that from the guidelines I like to emphasize is we found that a lot of people were okay with starting feeds, but not a lot of people were okay with advancing them. And that really the only way, and I'm sure we'll talk about this in just a few minutes in another way, to get people from point A to point B was to have some type of algorithm or a guideline or a pathway. Otherwise, the feeds were left on trophic and our goals were kind of misplaced in the patient's NPO for these periods of time. And so having a tool in place to remind the team of where we're going and how to get there was really important.
Whoops.
Sorry about that. I was trying to press the space bar to temporarily unmute and it went crazy. Thank you for that, Amy. I appreciate sort of all the conversations around thinking about the literature. It's already been highlighted. And as you can see, the citation that was referenced by all 3 speakers is up on the screen. And it seems like everyone sort of already answered this question, but just to say it kind of explicitly is what are some of the things that each of you take into account was as you shift from the question of is it safe to feed to how do we safely feed even when instability is present? Jemma, is that something?
The last one to speak, so I was going to defer to Marwa or Jemma first.
Yes, sorry, I can answer that one. I think to prioritise enteral nutrition safely in this population, we really need to agree on what signs of harm we're monitoring for. And then closely monitor these, but have the ability to pivot to other strategies if there are signs of harm. So as we've said earlier, as some of the other speakers have said earlier, there is sorry, what am I trying to say? There is this process that we're starting nutrition, but not necessarily, or enteral feeds, but not necessarily escalating it. And there is concern about GI complications, but the literature doesn't necessarily back that up. The most complications seem to be minor, whether that's because we're not escalating feeds and they're not having those complications. But I think we really need to decide on what what we are worried about the complications and coming up with a strategy as to how to best monitor those.
Thank you so much for answering that. And then let me now have us shift gears, and Jamie, I'll bring up the next case for you.
So this is a 6-day-old, 41-week girl admitted with meconium aspiration to a different patient population who's on PediECMO, now day 4. She's tolerated 2 full days of trophic feeds, and during multidisciplinary rounds, the dietitian recommends advancing the feeding volume to protein energy goals, but the medical team feels very hesitant for a reason or whatsoever. So that kind of leads us to Dr. Mansour, your thoughts on what are your unit's kind of target nutrition goals, whether they be numeric, based on kind of dietitian recommendations and nutritional recommendations with insensible losses accounted for, etc., or are they more conceptual, such as do you advance based on feeding tolerance, residuals, the ab circumference, like more clinical data?
That's an excellent question. So both. So when the prescription is first written by the clinical dietitian, it's number-based. So I pulled here the numbers. So for example, a baby like her 6 days old, 0 to 4 months, we will give somewhere between 100 to 130 kilocalorie per kilogram, and we will give 2 to 3 grams per kilogram of protein. That will be our initial prescription. And then based on all the factors that we previously discussed, we will determine if enteral diet is the safe way to deliver this amount safely. And then we start at 1 ml. So we will choose the formula. And usually if the patient does not have any contraindication or special needs, we'll start a standard formula that is appropriate for age. And then we'll start at 1 ml per kilo per hour continuously, which we are trying to change this to bolus to be more physiologic, but for now it's still continuously. And every 4 hours, we evaluate to increase by 1. So that's the guideline. This is what should happen. And that will be what is written in the prescription by the dietitian. Now, at bedside, comes a different story. So we have a goal of, let's say, the baby should be at 25 ml per hour of Similac. Sure. And then we start at 5 ml per hour, and then we start to increase to 10 to 15, and then it up to the provider. Will they stop the feeds if they have 1 episode of MSS or 2 episodes of MSS or more? Well, abdominal distension a little bit will be the holdup to advance the feeds, or we will stop the feeds. Becomes the subjective decision making is the main drive behind will they advance or not, despite the prescription by the dietitian. I can't hear you.
No, thank you. Thanks so much for going through that. And then sort of related to your answer there, Jemma, I was wondering if you could help us best understand, especially with the work you're doing on the consensus statement, is when we're developing ECMO-specific standards and nutritional goals, what are some of the targets that we should be individualizing for the patients?
Yeah, well, I think that we do need some overarching ECMO-specific goals, but you're right, most of it needs to be individualized in terms of route of feeding for and types of feed selected for different ages, when it's safe to progress with a feed, and when sort of what symptoms to look out for to back off. But I might throw this out to my other colleagues in terms of what they would think for individualized targets.
And maybe you can answer this in consideration of like the patient population as well, you know, like cardiac versus neonatal, etc.
So if there are no other comments, as I was writing the guidelines, I realized that I should be asking myself, if this patient wasn't on ECMO, what would I do? You know, it's an otherwise critically ill child. If they weren't on ECMO, I would do X, Y, and Z. And why or why not should that thought process be applicable to the ECMO patient in front of me? And what I found a lot of times is that the ECMO just scared me and us, the circuit itself, that they were at the end of the day a critically ill child, and there was no real reason for me not to feed them. So a standardized assessment, as Marwa mentioned, is something that we do here as well. We certainly don't have a protocol that's as intricate as the one that you described, and a lot of it is a lot more subjective at the institution that I'm at. But if I would feed the child otherwise, I try to not prevent the ECMO circuit from having me do so for that patient. But I say, okay, now because we are in circuit, let's think about X, Y, and Z, which things are applicable to this patient, which aren't. We have a lot of medical complexity patients in our ICU, which I'm sure we all do, a lot of complex care and chronic illnesses, and those patients can come in particularly malnourished. And so for those individuals, we have to think about them as people and what their baseline state of health is, and then tailor their plan accordingly.
Along those same lines, when you talk about kind of tailoring the plan accordingly, do you think that, there's a lot of literature in the neonatal population specifically, so this kind of might apply just to that. But with the data on breast milk and the safety and regarding specifically in the neonatal and the cardiac population, the necrotizing enterocolitis risk and osmolality factors, do you think that you can support these patients equally just by using breast milk, even though the protein and calorie requirements may be very variable?
I think so. So in our institution, what we observed is, well, first of all, most of ECMO patients in the neonatal age group are due to CDH. And that in itself is a reason why they will start on TPN almost always. But by the time they are able to tolerate enteral diet, mostly they were on express breast milk plus breast milk fortifier that gave them somewhere between 3 to 4 gram per kilogram of protein, and gave them 100 to 120 kilocalorie per kilogram. And that meant that we had to fortify their breast milk to 27 calories in average. I have seen few patients who are on 30 kilocalories per ounce, and the reported NEC was way below what we thought we will observe. Meaning when they are clinically stable and when it's clinically appropriate, they were able to tolerate high osmolarity and it was advancing to the full feeds. Jemma made a golden comment when she said, well, do we not observe side effects because we don't advance? We select patients. That's why we don't observe a lot of side effects. That is a maybe, because all of this is retrospective studies and observational studies. So maybe the way we feed patients and being overly cautious protect them from a NEC. That's a possibility, but at least in the patients who were fed with breast milk fortified up to 27 to 30 calorie per ounce was tolerated with no side effects.
I actually love hearing that, Marwa, because I think there is often a lot of reluctance to fortify breast milk in terms of the GI safety for these high-risk patients. There's the thought that breast milk is the best option. Not disputing that in terms of for all infants, ECMO or no ECMO, for its protective factors for the gut and the immune system. But it is a low protein and low calorie nutrition fluid. So I run into this quite regularly, that there is milk, and I mean, you just can't meet the requirements even at the lower end at 1.5 grams per kilo per day for an infant. At the very lower end of protein needs, you'd need 150 mils per kilo per day of breast milk, unfortified breast milk, which is often just not feasible in this patient group. So I love to hear that you're fortifying and meeting requirements that way.
Really quickly, before Vari and Amy, it seems like you're going to say something. I want to call attention to the chat for the group. If you guys could just check out the question I put in there, that will kind of guide some of our next topic conversations. Did you want to say anything else, Dr. Lee, about this before we move on?
I actually was, that prompted me to ask a question to the group, but I didn't know if that was okay. So I was going to ask if I could ask a question.
Absolutely.
Because Jamie, I was really struck by a part of your paper where you indicate that I think it was the self-identified people, the neonatologists, who said they wouldn't feed enterally ever at all in ECMO, and that was not a small number. And so I was wondering if there was anyone in the audience that offered that perspective. And it's easy to say as not a neonatologist, oh, it's safe and fine, and we should do this. But I'm a pediatric intensivist, so I was curious to hear the neonatology perspective if anyone was willing to offer. If not, that's okay. We'll just move along.
I'm not a neonatologist either, but we collected data on neonatology group and we collaborated with our colleagues. It's almost always a jointly made decision between the pediatric surgeon and the neonatologist, again, because most of the population in the NICU is CDH and or cardiac. So the cardiac surgeon will be part of the decision making regarding initiation and advancement of feeds. So it's not only the neonatologist. Now, 30% of the patients we collected data on, and I think my entire cohort was 50 something, they were on enteral diet by day 10 to day 14. So that's not very late for CDH. So I don't think it's impossible to do enteral diet on this population.
Do we have any neonatologists on that could speak to their thoughts?
Hi, this is Mona Lisa Patel. I'm from Loma Linda, California. I think from where I have worked and what I have seen within neonatology, there is a lot like a culture-driven style. So it has been such that, oh, we just haven't fed them. And we definitely do need to step out of that and do need to consider feeding these patients sooner. For sure, for CDA, for non-CDHers, for CDH patients, I actually wanted to discuss that more, with the group about what the style is with enteral feeding. I think Marwa was mentioning something.
Thank you for bringing that up, Dr. Patel. I think I'll bring up this article, and Dr. Mansour, I'm sure you'll speak about the one that it will be coming out soon. But for folks, just to, the conclusions of this, which I know all of you already know, but just to say out loud, are really thinking about optimizing the support in pediatric ECMO and individualized assessments, which everyone sort of hit on already, and really recognizing malnutrition as a risk factor. And so I bring this up to you to sort of jump off of what Dr. Patel was saying just now, as she was thinking about neonatology and everything that folks had brought up. So Dr. Mansour, do you want to start the discussion on that in terms of thinking about individualizing assessments and some of the literature that's out there and some of the new work that you're about to publish?
Yeah, thank you. So first of all, the review article, it started with me trying to find what is the answer for all of these questions that we are discussing, because it seemed to be very vague and gray zone how to feed these children. So first of all, what I concluded is one of the biggest barrier in this population is we cannot do assessment for their caloric needs, because the standard of care is, or the standard method, the gold standard is the metabolic cart. And Jemma, I will be very happy to listen to your expertise if you have tried metabolic cart in your unit, but virtually impossible to be used on ECMO, especially that it depends on VO2, like oxygen consumption and carbon dioxide production. So one, we cannot assess how much calories they need. And two, we don't know how much protein they lose in the circuit. We have an idea how much protein is lost in the CRRT circuit, and that's why CRRT patients will be on 50% higher protein than the non-CRRT patients. But we don't know how much protein is lost in the ECMO circuit. We also have a huge variability on when do we feel comfortable to do enteral diet. But what we do know is patients who are fed enterally early and consistently have higher survival. Is it because they were less sick or no? We don't really know, and I think that's a topic for more research, especially prospectively. Number two, we found out that it's easier and more feasible to achieve all the protein and caloric goals when we use TBN early, but the long-term effects of TBN are yet to be explored. And that's why we designed the study that we just got accepted. So we wanted to look at what happens if we use TBN for a long period of time, and is actually enteral diet associated with better outcomes. And granted, this is again a retrospective observational study, but it is very interesting. We found out that patients who continued to need TBN beyond day 14 had more circuit failure, had more circuit changes. And also that was associated, not causation, still association, but needing TBN for more than 14 days was associated with longer hospital stay, was associated with more ECMO need, but mortality was not different between the two groups. So it's quite interesting and thought-provoking that why are the patients who need TBN for more prolonged time have more circuit failure? Is it again because they are more inflamed and the circuit failure happened because of the higher inflammation, or because something in the TBN provoked the circuit failure? We don't know yet. Again, another subject for more research.
For
I think
the
that's so interesting. And, you know, it comes down to not knowing what optimal nutrition is. Are we, you know, it's that fine line between overfeeding and underfeeding and getting it just right, but we don't know what we're aiming for. So it's so hard to actually achieve this. To answer your question earlier about playing with the metabolic cart with these patients, I must admit I haven't tried it. We do have an indirect calorimeter on our unit. Our device is limited to weight cutoff of over 10 kilos, which rules out quite a number of our patients. And then I must admit I haven't had a play with doing the gas measures at the ECMO circuit and using the IC on the ventilator. But yes, it would be very interesting to do that. But yes, I think it really comes down to not knowing what we're aiming for. We use these predictive equations to help us determine what the energy expenditure in this patient group are, but really we need to use it as a starting point and then monitor their biochemical indices and their clinical parameters to make adjustments to what we're aiming for.
There's a couple questions in the chat that I think are interesting. And then we'll kind of summarize some thoughts and move on to another case. But someone wrote, Dr. Rahman, is there a need for is the need for TPN truly just a surrogate for acuity of illness? And I think, that would be the question more of TPN versus enteral instead of both, right? And so I think you kind of touched on that if anybody wanted to add to that. And then Allison Cowell asked a very interesting question of, does anyone use the VO2 calculator available on certain platforms nowadays to help determine these physiologic parameters? We are now incorporating the CDI monitor coming out soon that has a VO2, and so that's actually maybe ripe for the taking for some research, actually.
For the first question, we don't know if prolonged TPN use was a surrogate for how patients are sick, and that's why we are in the process of having a larger study with more N to know this and correlate the critical illness score with TPN use with the ECMO specific outcomes. For the second question, that's also another area of research and another area of development in our unit. We do not use VO2 measurement, which is a huge limitation in how we assess. We still use the shuffled or scuffled, how you pronounce it, equation to determine patients' basal metabolic rate.
I think Alice's question is really fascinating. Allison, do you all?
No, but we threaten to. We have the Spectrum Quantum now that we use on our smaller patients, and we have servo ventilators that we use most commonly, and so together, we are supposed to be able to use both to be able to figure out adequate, actual oxygen or calorie expenditure. But I have not yet put it into practice, but I think it is fascinating, especially in light of, we use a lot more CRRT than we used to. And so volume itself doesn't become so much of an issue. And so actually targeting to true caloric need and caloric expenditure I think is the way of the future. We just haven't quite operationalized it at this point. So anyone who has a guideline or a protocol, I'd love to share and see it. We can have a conversation because we need help.
That being said, I think we'll move towards, there we have a slide that we're going to show you guys of a paper that came out of Children's Hospital of Atlanta, so Emory's group, that actually does have a feeding protocol published, and they utilized it in their institution and their PICU population, and standardized actually starting feeds within 6 hours of ECMO initiation unless unstable, which was defined as blood pressure changes, fluid resuscitation need, vasopressor titrations, not vasopressors in general, but vasopressor titrations, etc. And they talked about the outcomes of before and after protocol implementation, and they were able to reduce their hours to improving goal feeds by 18.5 hours versus almost 60 hours pre-implementation. So this is one of the largest publications on this right now, and kind of ties directly back to the use of the recommendations from the ELSO guidelines and having a stepwise nutrition algorithm, and also ties to all of our speakers' work today and what their life goals have been, and hopefully what Jemma will be able to help create with an international consensus guideline on how and when we should start feeds can be used to create these protocols. But I think that maybe is the desire for a lot of people here. So I will say in the chat so far, after I asked that question, only one person said that they have an actual feeding protocol that they use. And so there's 54 of us here. And I'm alone who wrote the survey asking everybody what they do. We don't have one. So, and I think it's probably, multifold, as you guys would imagine. But anyways, going on to our next case with all of these incredible discussions we're having, I want to shift into this fluid word that we keep talking about. Vari, do you want to read this case?
Yes, I'd be happy to. Thanks, Jamie. This case is a 22-month-old on BV ECMO secondary to ARDS with a dual lumen neck cannulation. He's had good hemodynamics and oxygen delivery since the initiation of ECMO. And so the question we want to ask is, the first center that we're talking about has IV fluids for hydration. Was started when ECMO was started and maintained for days 1 and 2. Then TPN was then initiated on day 3 and continued, with trophic feeds being initiated on day 5 and maintained. And comparing that to another center that did IV fluid hydration on day 1, transitioned to some trophic enteral nutrition and TPN on day 2, with feeds increased and achieving goal by day 5 and discontinuation of TPN. And so when we're focusing on these things, we just wanted to have two very, very different practices to help us compare and contrast these centers. And so, go ahead, Jamie.
You go ahead.
Okay, so then the first question sort of related to this is, when we're thinking about the inter-center variation, especially in these two sort of ends of the extreme, if you will, observed in timing and route and advancement of feeds. Jemma, what are your thoughts around these really different centers and their outcomes and their impact on nutrition?
Look, I mean, I don't think what you're describing is that uncommon. I think that there is so much variation in practice between centres, mainly because we don't have a standard of care that we're all working towards. And while the overarching goals should be similar to our general critically ill population, like we've talked about earlier, the actual logistics of doing that is really challenging. So I might talk a little bit about a study that I've just completed that is I've just completed the data collection component of an prospective observational multi-site study on nutrition in pediatric ECMO patients. It's called Peanut ECMO. And we've looked at nutrition prescribing and intake both during and after ECMO across hospitalisation for all 7 of the paediatric ECMO centres across Australia and New Zealand, and we have 123 patients as part of that study. And this is unpublished and just at the, as I say, the very end of our data collection period, but some very early and high level results that I can talk to you about is that there is variation in practice between all of our sites around when we start enteral nutrition, when we start TPN, whether we use TPN, feeding tube placement, and also the use of renal replacement therapy during ECMO. So I haven't analysed any adequacy data or outcome data yet, and so these are coming. But I think until we can decide on what the best sort of starting place and way to progress nutrition is, scenarios like you've described here are going to continue because, you know, there's nothing for centres to sort of base their decisions on and progress with.
Do you guys seem to find that your team agrees, meaning what the nutritionist dietitian recommends is similar to the surgeon, similar to the ICU physicians and bedside staff?
Look, I think it really is quite a multidisciplinary approach, and it requires joint discussions and decision making and collaboration from lots of different input in terms of intensivists and dietitians, pharmacists, and the nursing staff as well. And as part of our daily ward round, we would discuss these patients' nutrition in terms of their fluid goals and their sedation management and their bowel management. And we would come to we would negotiate in terms of where we would start their nutrition, how we might progress that for the day, and whether they're at a target or not. And so this shared decision making and joint planning for the day, I think, is really important to make sure that these goals progress.
I think some of it goes back to having a protocol and an algorithm, right? And having buy-in from your team and everyone have agreed on your markers ahead of time. I mean, all of the nutritional data out there doesn't tell us how necessarily to write the algorithm in the protocol, but that having one improves outcomes as a whole. Same with fluid management, etc., right? Anything to add before we go into case 5? Either one of you, Dr. Lee or Dr. Mansour?
A brief comment. So this really highlights for me, I mean, I feel like you're spying on my unit that this is like 2 situations of patients that could just be across the hall from each other, very commonly encountered, and really, really highlights the need for us to really push nutritional science and research. And, randomized control trials would be lovely in this forum. I think if we just briefly take myself out of the PICU world, I think 2 other disciplines have had success for particular reasons. That's the burn patients and also eating disordered patients. And I think they have success in feeding patients because of very clear signs of feeding intolerance. Everyone kind of agrees this is when to stop. ECMO patients, I know at times are way more nuanced than that, but I think this just highlights that we need more research, we need more data, and we need protocols and guidelines, and for institutions to agree on this is what we feel comfortable with and this is what we know.
That was such an incredible reference. We can learn from our counterparts for sure. So moving to case 5 for the sake of time, because we want to make sure we get through all of this awesome work that you guys have helped us create ahead of time. Bari, do you have it? There we go. Perfect. A 13-year-old girl decannulated from ECMO following an 8-day course is found to have a 7-kilo weight loss and weakness in her bilateral lower extremities with 10% of loss of her mid-arm circumference. Reviewing of her caloric intake through her admission and ECMO courses identified that she did actually receive almost 50% of her goal feeds while she was on ECMO.
And so this case highlights for me one of the most important questions that has been sort of thrown around a little bit, which is, what are the outcomes that matter the most? Is it percentage of goal delivered, or early versus late, or intolerance events? What outcome should we be looking at to help identify success? And I'll take Dr. Lee, I'll send that to you first to help answer.
Sorry, if it's okay, I saw that Mara unmuted first, and I have some background noise, so I'll let her go.
Thank you. Well, I think the most important outcome is exactly what you wrote in your vignette. What is their weight, arm circumference at the end of the critical illness, and how much they are able to participate in rehabilitation? Because no matter what happened during their illness, if we could overcome this by good rehabilitation and good nutrition, that's the real success. So I don't know, we don't have data to say starting enteral nutrition on day 1 versus day 3 versus day 5 will definitely set them up for success, probably, but we don't have solid data. We also don't know. We know that achieving 60% of their caloric and protein need during the first 7 days per Dr. Mehta's studies will have way better outcomes and less mortality, especially when it's achieved enterally. That's well proven in the prospective studies. But again, I think if they are able to achieve good rehabilitation and they have less than 10% loss of their arm circumference and their weight, that's definitely the outcome of success. Now you can go, Dr. Lee.
Sorry, I still have the background noise, but I've thought a lot about this question because as physicians, we have, I think, predetermined ideas of what success looks like. But I think if we look at it from a family's perspective, in terms of, what do they consider success for their child? And it's really, I think, distilled pretty simply for most of the families that I talk to, which is survivorship, obviously, but avoidance of major morbidity. They don't want life to be completely different pre-hospitalization versus post. And so I think the outcome should be avoidance of that. And we're learning more and more about how proper nutrition allows these children to avoid major morbidity. And I think that's the outcome.
I'm just going to add to this. Sorry. Because I agree with you, Amy. Well, I agree with everyone. It's a very challenging question because I think that the end goal does need to be survival and morbidity, but then all of it feeds in together because what we're doing in terms of adequacy is going to impact on these longer term outcomes as well, potentially. I think a slightly different frame of thinking about it is also avoiding deficits, large deficits early on. So while that is achieving adequacy, it's also reducing those deficits early on, because as soon as we accrue these big deficits, there's really no catching up on it, because we can't overfeed, because that leads to its own complications longer term as well. So I think there need to be these two outcomes that we're working towards: survivorship and reduced morbidity and improved longer term outcomes. But this adequacy and reducing deficits all feeds into that as well. So it's very complex, really, to decide.
So I'm going to ask a hard question that I think all of you have just mentioned. It's basically, do we think that nutrition is something that can actually improve ECMO patient outcomes? And what I mean is it a true modifiable determinant that if it was a true modifiable determinant, then changing our nutrition practice would consistently in literature show that it improves outcomes, like survival, duration of ECMO infection, etc. Or do you guys think that we're still in actually a hypothesis generating phase, not knowing that the safety is always safe and that we don't know their actual requirements and the demands, and we know what we know from other literature, but we don't actually have an RCT in ECMO patients? And so do we think this is still in a phase where we're determining how the next best step would be to determine if ECMO nutrition matters, or do we think we have enough literature already out there to say that it does, specifically related to outcomes? Go ahead. Go ahead.
Yeah, I think we all can. I think we are beyond hypothesizing. Personally, I think we have enough data to show us both in the run-of-the-mill critically ill pediatric population as well as neonates in the ECMO population that this matters. It matters a whole lot. We have a whole lot of work to do in terms of going forward. We have a starting point, but the target is unknown, as we've described. But I think it's a very hard question. My opinion is the answer is yes, it matters.
Thank you. Does anybody else want to add to that?
I just wanted to say that the three of us are doing this research because we believe it affects the outcomes. And I think where my career is now is I'm just trying to figure out how to prove it, one, and two, how to find, I think all of us are working in silos or collaborating to see how can we best deliver the nutrition timely and efficiently tailored to every patient need. That's the question we are trying to answer, not if it's actually valuable or not, because I think all of us believe it's valuable, and the numbers and the research that's already published support this.
And then before we do our last case, there was just a wonderful question put in the chat from Dr. Jacob, I think it's Cobain, possibly from Loma Linda. He said, what is the most important multi-center study that you think from the three of you here today you want done to advance nutrition on ECMO? Maybe it's that we don't know yet, huh? Maybe it's too much.
Oh, yeah, it's a lot. Yes. So, in my mind, which is not, obviously way more easier said than done, is a agreed upon protocol of people from multiple institutions, like internationally. Like that's not, I think I'm thinking big, from institutions that we talk to for the ELSO guidelines for people across the, we're from the state of Texas, Marwa, but across the United States and Canada and Australia and New Zealand, we agree here's a protocol and patients truly get randomized, and we look specifically on about intolerance. So, because I think that's a huge reason why people are so hesitant. And so I would like to see one that avoids TPN and does enteral nutrition and assesses for side effects and adverse events. Now, will that ever really happen? I have no idea. Will we ever convince people to avoid TPN entirely? No. And I say that I'm such a hypocrite, myself included. Like I can see myself being like, nutrition is important. I would never do that. But I'd really like to see a international multi-institutional randomized controlled trial on enteral nutrition and its advancement in the ECMO and pediatric ECMO population.
I love the sound of that. That sounds so cool. Yes, I agree. I think some sort of an implementation study with some sort of a randomization design between centres would be amazing to really get to the bottom of outcomes and impact.
I think for the sake of time, Vari was going to kind of go to our conclusions just to see if there's anything else to add. I do want you guys to know the last thing we were going to talk about was a parent's impact of feeding. And so we all want to just recognize in this space that it is also probably in something that in research we're trying to remember more and more is the parents' impact of when we don't feed their child and their thoughts on that. So keep that in mind for future thoughts and future work together, editorials, things like that. The PediECMO's mission, of course, is always to focus on research collaboration. So go ahead, Vari.
Yeah, no, thank you so much. And yes, research collaboration through PediECMO. And thank you for folks for putting in your email addresses in the chat. And then this is a QR link that we would love feedback on for future educational opportunities that we can provide, and also linking to PediECMO in general, not only the education subcommittee webinar. And we really appreciate everyone's time and our three speakers and our multinational contribution for today's topics and the really important discussions that we're having about both collaboration with centers and also recognizing the importance to collaborate and align with families as we think about nutrition on ECMO and really having the best outcomes possible. And so if any of the speakers would like to have another concluding statement, otherwise, thank you so much for your time.
Thank you for the opportunity.
Yeah, thank you
so
for
much.
having me. I've loved this discussion. It's been amazing.
Same here. Thank you so much. I appreciate this discussion and I appreciate the opportunity to collaborate and find other people who are interested in the same research questions.
Absolutely. You guys were amazing. Thank you so much for today. There's lots of thanks in the chat. We really appreciate your time and your commitment and how much work you put into this ahead of time.
Bye, everyone. Thank you.